it will compress the portal triads, the portal and hepatic veins inside the liver. So the pressure inside the liver will become increased because of the compression, and it mounts on the portal vein, and there is portal hypertension. When portal hypertension occurs, it means that cirrhosis occurs. I repeat, when portal hypertension occurs, it means cirrhosis occurs. The complication of cirrhosis is manifold. Some of them are discussed here. Because of the time, I have to go in a hurry. The esophageal varices because of the portal hypertension. Ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, coagulopathies, gastropathies, and so on and so forth. There are other complications which are not written here. These are the complications one should know, or idea should be there. For third year person, there are certain complications of cirrhosis which are important. In the final year, I will discuss every part of it in detail. The varices and the variceal hemorrhage occur because of the increased pressure in the portal vein. It is the junction between the systemic and the portal circulation, the gastroesophageal junction. And it is the splenic dilatation because of the increased portal venous inflow and variceal growth. Now the cirrhosis will lead to the resistance to the portal flow. It will cause the portal pressure to increase. This will result in two things. It will reduce the splenic arterial resistance, and it will increase the portal blood inflow. So inflow is increased and the resistance is decreased. It means the pressure is increased. It will impact on those places where there is anastomosis between the systemic and the portal circulations. There are three sites. Only one site is important, and that is gastroesophageal junction, where the esophageal varices occurs. The second one is at the rectum, where the inferior or the middle rectal veins anastomosis, the anastomose with the inferior mesenteric vein. It can cause, in some cases, the varices there and hemorrhoids. The third place is around the umbilicus, where the para-umbilical veins of the ligamentum teres is anastomosing with the inferior the vein which is arising from the femoral vein. It is called the inferior epigastric vein. So this is how the portal pressure influence on the different sides of the body. Now you see now the varices increases in diameter progressively, and again it will cause the varices, and the varices will rupture and cause hemorrhage. The hemorrhage will cause hematemesis. This is the endoscopic view of the esophageal varices. So decreasing portal pressure reduces the risk of the variceal rupture, of course. You reduce the portal pressure, transmural pressure, it will be reduced, and barracks radius will be reduced. The wall thickness of the veins will be increased, and there will be variceal wall tension will be decreased, and there is decreased risk of rupture. In cases of the compensated type of cirrhosis, we will give the drugs. For example, the beta blockers like propranolol, the calcium channel blockers can be given. The nitrates can be given. Nowadays they are also using the other drugs as well to reduce the pressure. And decrease in the hepatic venous pressure gradient. Now what is gradient? Gradient means that in the hepatic vein, you know what are hepatic veins? There are 4 hepatic veins which are draining into the inferior vena cava. Decrease in the hepatic venous pressure gradient, you minus this pressure from the portal vein pressure. This is called the hepatic venous pressure gradient. If you decrease it, the pressure to less than 12 millimeter, there are the least chances of rebleeding. If you increase this pressure to more than 20 or more than that, there are more chances of rebleeding. The treatment of varices is, in cases of the persons which are, I have already said, that they are compensated cirrhosis, there is no hemorrhage. And because there is no hemorrhage, there is no hematemesis. If there is hematemesis occurs, then you will go for the management. If this acute variceal hemorrhage, number 1, reassure the patient. Now, look, what I am saying are the words which are golden words. Reassure the patient, manage the shock first by giving the blood, whole blood, or you give the products of the blood. If it is not available, you give saline, or if it is not present, you will give the dobutamine or dopamine. If it is not present, then you can give the plasma. But in any way, the shock should be managed first. Number 2, you have to stop this bleeding at any cost. In the wards, at one time we are using the vasopressin. Vasopressin injections are available and they are very effective treatment in those cases where there is no associated ischemic heart disease. It will work like anything. You inject and the patient, the bleeding stops. Now, if it is not available or you do not want to use, you can make a drip of if the patient is ischemic heart disease, you give the dinitrate intravenously in a drip form. It will reduce the pressure and bleeding can be stopped. If you fail, you will give the octreotides, somatostatin and analogs subcutaneously, and then call the endoscopy to help you. Before the arrival, you can use the balloon. Balloons can be used. Sense-taking tube is placed in the lower part of the esophagus. There are balloons are there. There are 2 types of the balloons, the tri-lumen and the bilumen. There are 3 bulbs or 2 bulbs. They compress the varices and the bleeding stops. It's a difficult one. If it fails, then the endoscopy will be done by the endoscopist and it will go for the ligation, or it will go for the cauterization, or it will cause the removal, whatever procedure he wants to do. If it also fails or the rebleeding occurs, then go for the transcutaneous intrahepatic portal systemic shunt, that is called TIPS, This is the surgery which we are doing in 2 or 3 centers in Pakistan. It is the bridge between the hepatic transplantation and the other measures. Tips can prolong the life of the patient. Now, if it fails or the tips are not possible, then you go for the surgery that is called the anastomosis between the portal circulation and the systemic circulation. So the pressure of the portal vein is shifted to the systemic side. It will increase definitely the pressure inside the systemic circulation rather than in portal vein. There are 2 types of shunts. This is called shunting. The shunt may be selective and it may be non-selective. If it fails, then the last resort is the resection of the lower part of the esophagus by the open surgery, thoracic surgery. This is the last resort, which I have told you just now, one by one. 1, 2, 3, 4, 5, 6, 7, 8. It fails. It fails. What you do? When it fails, what you do? This is very, very important, doctors. If you can understand like that, there will be no problem. The ligation is seen in this diagram. Transjugular intrahepatic portal systemic shunt is elaborated in this diagram. The second important complication is ascites. Ascites occurs because of the many causes. In more than 70% of cases, it is due to the decompensation of the liver functions. There is cirrhosis of the liver. Otherwise, the peritoneal malignancy, heart failure, peritoneal tuberculosis, and others, pancreatic Budd-Chiari syndrome, that is the blockage of the hepatic veins, Budd-Chiari syndrome, and nephrogenic ascites because of the chronic renal failure. We usually see the ascites, the accumulation of the fluid in the peritoneal space. There are many theories behind it. No theory was accepted. Only thing they accept is there is the water and sodium retention and how it occurs. Now, cirrhosis will cause the hepatic venous outflow block and sinusoidal pressure will be increased. I already said that the hepatic vein pressure gradient is more than 12 millimeter. It will cause the oozing, the liver weeps, and ascites occurs. Another condition which is important in cirrhosis is arterial resistance, which is reduced vasodilatation, which will cause the reduced effective arterial blood volume, and it increases the activation of the neurohormonal systems, renin, angiotensin, aldosterone mechanisms, and it will act on the distal convoluted tubules, and there is sodium and the water retention. Sodium and water retention occurs in this condition. Now, vasodilatation and ascites result from an increase in the nitric oxide. The portal hypertension will cause the shear stress and nitric oxide will increase, and it can cause many problems. Vasodilatation, activation of the neurohormonal system, sodium and water retention, and it has got a place. It is one theory, it is nitric oxide which is responsible. The ratio, we always remember, we should calculate the ratio, SAG, the serum ascitic albumin gradient. You will calculate the serum albumin total and minus the total albumin in ascites. This is called the SAG. If it is 1.1, it is normal. In most of the cases, if 1.1 is there, it is you cannot say that it is transudate or exudate. If it is more than 1.1, it means that transudate occurs. If it is less than 1.1, it means that it is exudate. It is infective phase. Remember and repeat it. More than 1.1, transudate. Less than 1.1, it is exudate. So ascites can be characterized by the serum ascitic albumin gradient and ascitic proteins. This is the chart which is in front of you. You should not remember this. Only thing which you remember is SAG. For example, you have described that this ascites occur because of the portal pressure which is increased. And portal pressure has caused the sodium and water retention. How will you manage it? The thing is this, the first step is the number one, reduce the sodium of the patient. The water intake should be reduced. Thirdly, the diuretics should be given. The diuretic may be loop diuretics or it may be the potassium sparing diuretics. It may be aldosterone antagonists, receptor antagonists, etc., etc. There are many drugs which we use. Other than that, you use the propranolol to reduce the pressure, or you will give the calcium channel blockers to reduce the pressure. They are associated therapies. If it fails, then you have to remove by paracentesis. You reduce it by the paracentesis. Repeat it, the paracentesis. The paracentesis is very important, and the examination of the fluid will tell you whether this is transudate or exudate. If it is exudate, it means this is not related with probably with the portal hypertension, because tuberculosis is the commonest cause there. If the SAG is less than 1.1. So ascites is definitely managed like this. You remove the fluid in the end. If all the failure occurs, you go to remove it. It is called therapeutic paracentesis, ascitic tap, and you replace by the salt-free albumin. If there are 3 or 4 sessions and you failed, then the only thing you can do is the hepatic renal or transplantation. But because hepatic transplantation is not very common in this country, the bridge surgery can be done. That is called, already mentioned out, it is TIPS, the transcutaneous intrahepatic portosystemic shunting. Surgery can save the patient from the reaccumulation of the fluid. So I have already said about the sodium restriction and the water restriction, etc., and drugs already mentioned. So the diuretic therapy is the mainstay of the therapy. The other complication is the spontaneous bacterial peritonitis. What is this thing? The fluid which is accumulated inside the peritoneal space is a very good media for the growth of the bacteria. The bacteria can come from the blood, the bacteria can come from the intestines. Now, if the bacteria invasion occurs, it will cause the transudate to become exudate now. Now, on examination, the essential of diagnosis, clinically the patient present with the fever and the tenderness of the abdomen. There are 2 things which is very important. If there is tenderness in the abdomen, ascites is always non-tender. If ascites, the patient with ascites is in tender state, it means that there is something going wrong. You go for the tap and see how much leukocytes are there. At least 500, you have to describe it, you have you should have at least 500 leukocytes per cubic millimeter, in which 300 neutrophils should be there. At least 300 neutrophils. If there are no neutrophils, rather than the lymphocytes are there, it means that the tuberculosis has occurred on ascites. And I remember that we have written a paper where hepatitis C, which is causing the portal hypertension, and refractory ascites, there are 70% of these patients develop tuberculous peritonitis. So there are a lot of chances of the tuberculous peritonitis in these patients. However, I am talking of the spontaneous bacterial peritonitis. We don't know how it occurs and why it occurs. We don't know. The thing is that the essential of diagnosis is important. How will you manage it? You give the antibiotics. Which antibiotic you choose depends. The third generation cephalosporins are very good. The quinolones, the second generation or third generation quinolones are very good drugs. Just for the prophylaxis, you can give the norfloxacin, which is easily available, 400 milligram. One OD can be given to prevent it. It is possible afterwards. So the spontaneous bacterial peritonitis occurs because I already said that these bacteria can invade from the blood. These bacteria can invade from the intestine directly from the wall. Fever occurs, jaundice occurs, abdominal pain and confusion, abdominal tenderness, hypertension. And this condition can cause hepatic encephalopathy also. And treatment is already mentioned out in my discussion. Prophylaxis with norfloxacin mainly. Now, hepatic encephalopathy is a very important complication. It is type A associated with acute liver failure. Type B is associated with the portosystemic bypass. Surgery has been done with intrinsic hepatocellular disease. And type C is associated with the cirrhosis and the portosystemic shunting. We usually see type A type of the hepatic encephalopathy, so I will discuss type A. In type A, it is rapid onset, frequently fatal. Main cause is the cerebral edema, and treatment is rarely effective and short of the liver transplant. Now, how do you do the pathophysiology of this hepatic encephalopathy is this. The ammonia is not converted further into uric acid. Ammonia can cross the blood-brain barrier. The urea and uric acid cannot cross the blood-brain barrier. So ammonia will act on the upregulation of the electrostatic peripheral benzodiazepine receptors and the non-neurosteroid production and the modulation of the GABA A2 receptor. And there are other theories as well. Markaptanes are releasing. Endogenous benzodiazepines may be responsible. There are many theories behind it. Nobody accepts all theories. Only thing they can accept, the Americans says that the ammonia is the culprit agent, yes, in most of the cases, but they have seen the normal ammonia levels in 20% of cases. It means that it is a multifocal type of a problem. Not ammonia, but other products or chemical substances are also acting on the brain. Cerebral edema associated is important, which is causing the patient for the encephalopathy. Then what is encephalopathy? The encephalopathy, in this you find the history of the patient. The patient has got, usually said that he was taking the diet which was restricted diet. He was not on that restricted diet. Patient usually have given the history of constipation often. They have taken the fluids in a very, very regular fashion. They have taken the salt in a regular fashion. And they have esophageal varices which was treated, or they have done some surgery of the abdominal surgery has been done. There are more chances of hepatic encephalopathy. Or there is enteritis which has occurred. Now, actually what happened in constipation is the proximal to the constipated material, there is bacterial overgrowth, and the bacterial overgrowth will cause the more proteins to form. Because of the protein metabolism is disturbed in the liver, it will not convert the ammonia into the uric acid and creatinine and urea, and this will cause ammonia to rise or other substances to rise, and it will act on the brain, and the patient will become drowsy, and only thing is the drowsiness. First of all, increased drowsiness, patient become, he does not want to talk, he wants to take sleep. There is the reversal of a sleep pattern, and there is electroencephalographic changes occurs as the disease mounts, and he becomes delirious, he becomes stuporous, and there is pre-coma occurs and the coma occurs. These are the stages which are seen in this diagram, which is not for you. Only thing is the drowsiness which is increasing and leading to the coma. You cannot remember all the things. On examination, you see the patient become very quiet, and you see the blood pressure is usually down. You see the patient is likely to be dehydrated, anemic, and all peripheral stigmata of the liver is present. With one thing more which is very important is the fetor hepaticus, which is coming out, the smell which is coming from the mouth, and the hands have got the specific types of the tremors. The tremors are called the ascites, flapping tremors. You flex the whole hand and then suddenly slap it. The patient becomes, will show the flapping of the fingers very, very sharply. This is very important sign of this disease. Ascites. This is called ascites. The all other features of the neurology is present. Confusion, drowsiness, somnolence, coma, I already said. This is easy to remember. Ascites is shown here, the flapping tremors. The ammonia is the culprit, but I said that Americans physicians do not accept this theory. They said that 20% of the cases have got normal ammonia levels and even low ammonia levels. The other substances are also there, which they have not detected yet. Markaptanes, for example, the endogenous diazepines, for example, and other substances as well. Now, in the minimal hepatic encephalopathy occurs in 30 to 70% of all cirrhotic patients. They have become drowsy, they are lethargic, they cannot work properly. So what will you do with these patients? Try to avoid the infection and GI hemorrhage and prerenal azotemia. Sedatives should not be given. Constipation should not be there. Try to relieve the constipation. So lactulose should be given. Lactulose is a substance which is the ideal substance for hepatic encephalopathy. The lactulose is given, it is converted in the stomach, and the lactic acid is formed, and lactic acid is formed in the intestine because it is acidic in nature. It will bind out the hydrogen ions, and it will cause the water and carbon dioxide is formed in the stomach. And in this way, the nitrogen is also combines with the oxygen and it forms the nitric oxide inside the stomach. So a lot of the nitric oxides they are releasing in the stomach will be come out in the stools. This is one way of action of the lactulose. The lactulose can act as also absorbent of the toxins. Lactulose is also causing the bacterial overgrowth to become reduced, to reduce the bacterial overgrowth. Lactulose is also causing the contraction of the peristaltic movements. It will relieve the constipation and the loose motion occurs. So all the substances which are injurious to the liver will be excreted via the stool. The second thing which is very important is the protein restriction. The protein should be restricted. Only 1 gram to protein is allowed in these patients. 1 gram protein per kilogram body weight is allowed, or less than that is allowed. I will say 500 milligram per kilogram body weight, not more than that should be allowed. Salt is hardly should be given, it is 1 gram per 24 hours. Water can be given to 1.5 liter to 2 liters. This will help in the management of the hepatic encephalopathy. The bacteria which are present already in the stomach will be killed by the different type of the antibiotics, which are called the enteric type of antibiotics. At one time, neomycin was used because it is the hepatic, it is renotoxic. Toxicity occurs with this. They stopped it. Now they are using the other drugs, the metronidazole. Metronidazole is very good drug, which can be used. Now they are using the norfloxacin, ciprofloxacin, and related quinolones, which act on the intestine. The cephalosporins can be used. That is ciprofloxacin. It will kill the bacteria inside the stomach, so that the burden of the proteins in the bowel is reduced. Now, how do we manage this hepatic encephalopathy? I have seen the cases from pre-coma, they become drowsy and then less drowsy and come out from that. I have seen many cases with this management which I have just told you. The participant already said the person is not restricted to the diet. He has taken all the proteins and the salt and other things. He has become infected and other things which I have already told you. The actions has been described, which has already said that how the hydrogen ions released, it will combine with the nitrogen. The ammonia which is present in the stomach will combine with the hydrogen ions which is released by the lactic acid, and it is called ammonia. And ammonia will act as the osmotic type of purgative. It will also help in the movement of the peristalsis, and the urease producing bacteria will be decreased because of the increased lactic acid. Lactic acid will also cause the it is a good absorbent, and it has got the increased cathartic effect and the loose motion occurs. These are the action of the lactulose. So the thing is, if it fails, then you have to go for the other things. The liver transplantation is the answer, and the bridge surgery, that is TIPSS, can be considered if transplantation cannot occur. It is not possible, then you go for the tips. Now, hepatorenal syndrome is a syndrome. There are certain substances they don't know how it occurs. They are releasing from the high blood pressure and act on the kidney. The important thing is this is type 1 and type 2. Type 1 is rapidly progressive renal failure, doubling the creatinine levels, and type 2 is more slowly progressive. The thing that the essential of diagnosis is this: number 1 is liguria, number 2 is hyponatremia, which is very important. The sodium level is decreased in this case. Liguria plus hyponatremia, they are prone to develop hypoglycemia, and of course hypokalemia, they can cause the potassium levels to be disturbed, and the other thing is the creatinine levels is increased. Creatinine clearance is reduced to less than 40 or less than 20 milliliter per minute. And these are the essential diagnosis of hepatorenal syndrome. There are many theories behind it, how it occurs, but never accepted by any one physician. There are many theories which are behind it. Only theory which is accepted is there are some substances are releasing from as a result of the blood pressure from the liver. They act on the kidney. Kidney is healthy otherwise. It can be transplanted even. I will repeat, the kidney is anatomically is normal. It is physiologically abnormal. So it can be transplanted after the death of this patient. It is normal kidney. There is no destruction. So the thing is this: how will you manage this case? This is the now the management of this case is that you follow all the instruction which I have given to reduce the portal pressure. If the portal pressure becomes reduced, along with the diuretics you will give, and along with the acid-base balance, the fluid balance, the patient will come out from this condition. So the hepatorenal syndrome occurs means that the patient is on the last stages of the disease. It is a bad sign. Many theories have been suggested that the hepatorenal syndrome occurs means that you have to go very quickly to the renal transplantation or TIPS. Otherwise, in very few days, the patient will not survive. There is another problem associated with the portal hypertension and cirrhosis, that the lungs are involved also. Heart ke bare mein, I already said, there is high output cardiac failure with the portal hypertension and in cases of the liver cirrhosis. But the lungs are involved. That is called hepatopulmonary syndrome or portopulmonary hypertension. It is a hepatopulmonary syndrome, which is a gas exchange problem. It is characterized by the arterial hypoxemia, and that may be very severe. SpO2 level decreases, PO2 level decreases in this case. How it occurs? Again, the same theories. There are certain substances which are releasing from the liver. They don't know the nature of the substance. And the clinical picture is that in the setting of the chronic liver disease, the axial dyspnea may evolve into extreme debilitation. The prevalence is 5 to 10%. Associated findings are finger clubbing, cyanosis, and spider angiomas. That is the peripheral stigmata of the liver.